Dziękuję za zaproszenie. I'm sorry to bother you in English because my Polish is too poor for a complete lecture. So, just to show you the distance between my University of Greifswald and Warsaw, so we are very close to Poland. It's the Baltic area. This is the medical school of Greifswald, one of the most modern in Germany, just ended a couple of years ago, the old city. So I would like to share a few thoughts on the problem of the medico-legal situation we face with the American FDA notifications and how we should react on that. So we have controversial issues. It's the medico-legal aspects around the world. It's the surgeon's training and experience that is very important. And the basic research starts 10 years after the launch. I will give you a few ideas on that later. Many products are taken from the market, so we have to reorient what we use in our daily practice. And how should we react on the FDA? So you see there's publications in all different languages, use of vaginal mesh in the face of recent FDA warnings and litigations. We have these thoughts in Germany, and you will face that in Poland as well. I'm quite aware of that. So just to start to show you, I love this study from Lucian Lieb, who is in the psychiatry in Harvard School, who looked at catastrophes in the world. So the safest thing, with only one lethal death on 100,000 actions, is scheduled airlines, is European railroads. It must have been before Fukushima, because nuclear power is not that safe. And then come the regulated, this is driving, chartered flights, chemical manufacturing, and then you see the three dangerous things in our life where more than one participant dies on 1,000 actions. That's bungee jumping, mountain climbing, and healthcare. So we are in a very dangerous profession. So preparing last year's workshop of the IUGA meeting in France, I did a personal review of the situation around the world. And I found that medico-legal heaven apparently are the Nordic countries. It's extremely seldom, there's no insurance needed. There's 1 or 2 cases in 20 years, told me the chief in gynecology in Helsinki. And the government pays for everything. Only if you have a private practice, you need some 50 euros for insurance. So if you come to countries where you wouldn't believe it, like India or in Bangalore, I heard from one of my recent fellows that the doctors now all need an insurance. No insurance, but starting is all the Maghreb areas, Jordan and all these countries. In most European countries, clinical work is insured by the institution and private work has to be paid by the doctor. But I know, if you look at the Czech Republic, the hospital will take care of compensation, but then will take 3 or 4 monthly salaries of the doctors responsible. So you might face solutions like these in Poland, I don't know. And in the USA, this is really medico-legal hell. So there's about 100,000 lawsuits currently filed in the US to address the injuries that come from pelvic mesh. 100,000 lawsuits. And in 2008, the FDA declared mesh complications rare. By mid-2011, they declared it not rare, sorry. And you know how quick the gossip goes along, so everybody in the United States can apply to FDA and send in whatever pleas and whatever criticism on products, and they go straight to court. This is the number of legal cases in the United States from 2006. It was 568 to 2014. 15 is not yet accomplished. 86,000 court pleas in the year of 2014 for complications of meshes. Just complications of meshes. So this is the famous Mrs. Linda Gross. She's a nurse, and she got a compensation of $11.1 million for a mesh complication. And in 2014, it was Martha Salazar who got $73 million. You must understand 60% of the money goes to the lawyer. but nevertheless, if you get $30 million for a little mesh complication, I have a nice caricature that shows the patient go into surgical theater, can't you make a little mistake, I need the money badly. So Johnson & Johnson has retired all their products of mesh surgery from the market, and you see they offered $120 million to settle thousands of injury lawsuits. The offer resolves anywhere from 2,000 to 3,000 lawsuits just against Johnson & Johnson meshes. And this is the recent publications of this year. In January, for immediate release, FDA strengthens requirements for surgical mesh for the transvaginal repair of pelvic organ prolapse to address safety risks. And I did not put in the name of the company, those using it know it. The next major company has taken all their mesh products from the market with the date of March 21st, just a couple of days ago, and said, related to women's pelvic business, unfortunately the current legal environment and the ongoing challenges associated with vaginal mesh product liability are key drivers for this decision. So they stress that their products are good, but because of the medical legal situation, they stop delivering them. And there's no new production, nothing. So if you take situation in the United States, 77.3% of the obstetricians gynecologists have a legal case. And you see how many? 2.6 claims per career. It depends a little bit the area. But I tell you, if a colleague claims from the United States that he has to pay now $58,000 for his insurance, I have to tell him, give me your 3.7 million income per year, I pay these 58,000. So you always should not look at the direct figures, but the correlation and the situation in that country. So there was a nice study following a previous one from 2002 from Gamal Ghonim, who looked how these messages of the FDA changed the mind of the different areas, and you see that in North America there's a decrease of 45% use of mesh, and there's other countries where it's even more. But the reaction is very variable around the many countries. If you take Europe, in France and in Germany, they say we have so good experience in own data, they did not change their mind at all. And in the Netherlands, there's a contract between the Dutch Society of Obstetrics and Gynecology and the government that has strict laws with 2 certified surgeons and annual audits of the departments, so the use went down to 1%. 1% of the previous use of alloplastic materials. Coming back to the United States, they continue to use it. The urologists use it. That's the amazing thing, not the gynecologist. And if you look, and this is one of the first data I will show you, reoperations with no mesh and reoperations by the use of mesh. You see that the number of reoperations necessary after implantation of alloplastic materials is much higher than with traditional reconstruction. And we should think of it. Nevertheless, again, stick to the figures, complications are rare. You see 2.2% without and 3.3% with mesh. This is a number of reoperations after primary correction. This is not too much, to be honest. And urinary retention, again, with mesh is higher than without using mesh. So the big problem when they produce these nice kits that you just rip off and have the trocar and click in your mesh, that incompetent surgeons found themselves suddenly looking rather competent. So they didn't need anatomical knowledge and separation of layers and tissues. They squeezed in their trocar and clicked in the mesh, and that was it. It looked very simple, but it wasn't. Carl Gustav Nielsen, who unfortunately left us last year, described for Finland that you need more than 40 operations per year. So the expertise of the surgeon is very important. I would not discuss whether it's 30 or 40, but somebody who does only 5 or 6 per year should stop doing it, because he has no expertise. And you see, the less you do, the more complications you have, because you have no skills with the procedure. So what should we do? I mentioned already that the studies on what is happening biologically with these alloplastic materials started 10 years after the introduction. And you see they all have inflammatory and tissue remodeling problems. 20 years after the polypropylene slings came on the market, they started to look at the risk and the prognostic factors, which is not a very scientific approach. And there is nice studies in animal experience now that look, if you implant alloplastic materials intra-abdominally in different layers of the abdomen, in the small pelvis, you see they all react, and it makes no difference at all whether you have it plasma-coated or titanium-coated, they all react, and you cannot predict how they do. And the next big problem is the change of paradigm of our patients. We have to know that what the patients are willing to accept. This has changed in recent years, and this has changed and will change in Poland. We need a good informed consent and an acceptance by the patient. There's a nice study from Dudley Robinson who asked the patient, which rate of complication are you willing to accept for which success rate? And it's amazing. 57% are happy with a 60% improvement if they have no complications. And only 23% accept a major surgery with an 85% success rate, but 2% complications. And I think many male, I have to say that, surgeons never believe what it means to a woman that just needed 3 or 4 pads before surgery and after that has to self-catheterize. This is an awful procedure for women. And I always fought with urologists all my life that they should not say, ah, she has to self-catheterize. This is an awful procedure. If you had nothing but a reduction of quality of life, no serious disease. So we have to take this in account prior starting surgeries like these. So the objective healing of continence or prolapse does not guarantee satisfaction. Many doctors are happy with the success rate, with the result of their operations, but ask the patient whether she is happy. Achieving sexual lifestyle activity goals stands for satisfaction. Repair of prolapse does not automatically mean full satisfaction. Maybe the prolapse has disappeared, but she has scars, she has dyspareunia, and this is all of these things she didn't want to have. So a recent president of the German Society of Gynecology and Obstetrics said, who with a minimal irritation is able to feel a maximum degree of suffering is a modern being. So we have a lot of princesses on the P. So the attitude of the patients is changing completely. And we have to take this in account prior starting surgery. And Ulf Ulmsten said there is no condition or disease that cannot be made worse by surgery. And we should always take this in account. So this was the original TVT. But who really stays with the cookbook? Everybody has his own modification. And if you look at patients after TVT where the exertion of the sling is here in front of the pubic bone, this was a lady both in front of the pubic bone. The right one was in front of the pubic bone. The left one went through the bladder to this exertion. So this is not the original TVT. So the idea went off like a rocket, no doubt. And I'm very proud that I'm part of this Nordic team. I was the first surgeon in the video distributed around the world for TVT. It was me who did it. So somebody who says he opposes alloplastic materials, it's not true. I'm fully convinced of this idea. So it was done in my department. Ulf was sitting behind me and showed me how he wanted it to do. So I'm fully convinced of that idea. But I was not convinced of 52 Me Too products that came on the market, at least in Germany. Most of them have no data at all. And this was this famous paragraph 510K in the FDA rule. It's comparable with, they came with new products that was never tested in patients. There was no studies at all, and they were all on the market. We have to know that the materials are very different. The elasticity is very different. If you are an experienced surgeon, that makes no problem. But if you don't know how to handle an alloplastic sling that is completely stiff, or like the spark, you can extend to twice its length. It makes a big difference for the result of the patient. So they are very different. And I did nice studies in Prague with my friends there with the new anchoring system for the slings. I always say they remind me James Bond when he wants to climb a wall. But if you look at these little plastic materials, how do they really support a cuff from a 110 kilogram smoker? So you see the difference in the resistance for extraction. This is a technical equipment. And just to remind you already, see how tense an Amreich Richter suture is not competitive with all the others. It's much better. It has real strength. And you know that there's very different materials, and the degradation of the material is different. This is a polypropylene fiber after 1 year. That is what it looked like. When I started in urology, we had nylon. They were all stiff and hard because they lost their softener. And this happens with all alloplastic materials in the body. You know that from drainages and catheters that are lost. They get completely stiff and hard. And that is what happens with all these materials. So there's very different long-term degradation. So what should we do? We first should look at the data that we have. So we should not compare traditional operations of the old-fashioned time with old suture material. We should not compare alloplastic materials that have come and gone. This is unfair. This is not good statistics. They all have gone. They are not there anymore. We should not talk about materials that are not on the market anymore. And that happens in Cochrane and in many other meta-analysis. They still include products that are not there. How successful are the slings? This is a study from Sweden. 941 patients that lose urine after 12 months. Satisfaction rate after TVT. It's a disaster. It's not 94% or 98% like the primary authors would have loved to see. There is a follow-up of 17 years now from Carl Gustav Nielsen, but we have to be honest, it's only 42 patients. So the result of 42 patients doesn't tell too much. We have to continue with this long-term follow-up. Nice study from Austria. They looked at the reasons for dissatisfactions 10 years after TVT. This was a study group, and you see dryness was achieved in 60.3%. 60.3% after TVT were dry after 10 years. This is comparable to our traditional operations. It's not any better. 22.7 were improved, but what is improved? You need 12 pads prior surgery and after that 9 pads. There's no definition what is improvement, so be always careful with this name. And 10% were even worse. They had OAB and other symptoms of obstruction. So we have to take into account that we can produce a lot of harm to our patients. So if you look at the public press, not only the medical journals, this is a publication from the New Yorker that says many results that are rigorously proved and accepted start shrinking in later studies. We know that very well from introduction of many new products. At the beginning they are just wonderful. They love to publish more than 100% success rates, direct cooperation with God. And if you look at that after 5 or 10 years, it shows that it's not true. We have to be honest. So I come back to old-fashioned procedures. I love the open colpus suspension with a little routine. It's a small incision. It takes you 20 to 30 minutes. And never change a winning team. I have experience of nearly 5,000 colpus suspensions in the last decades. And why change it? And I was criticized by Linda Cardoso when presenting during a yoga meeting this operation. Said, why do you talk about an old-fashioned operation nobody does anymore? This publication came from her department. What to do when midurethral tape fails. Rediscovery of open colpus suspension. But who is still able to do that? They all are used to put in the trocar for the midurethral sling, and many lost their skills to do traditional anti-incontinence procedures. That's our technique, 2 sutures, very loose elevation, approximation, not complete adaptation. That's why I don't like the word birch, who try that. And that's the same thing with prolapse correction. If you really look at the data of recurrency rates after traditional reconstruction, you see that the anterior compartment, of course, has a failure rate of around 15%, but the apex and the posterior compartment have very good success rates using native tissue without any mesh if you know the technique. Apparently, there's a big gap between the knowledge and the skills of different surgeons. These are the results for anterior repairs in different studies. You see that it's from very low and really awful to very high and good. So apparently there's a problem of skill. Many countries around the world don't know anatomy nor reconstruction anymore. And I tell this very honestly, for the United States, I only know a handful of American gynecologists that still know vaginal surgery. All the others know laparoscopy and whatsoever, but not vaginal reconstruction. So this is our anterior repair, and if you have good and stable material and take the cardinal ligament for reconstruction, you have nice success rates. So look at these awful statistics you see here. Of course, with a mesh anterior repair, the anatomic result is better than with native tissue. But if you look at post-operative urinary incontinence, you see they favor the anterior repair. Because with the mesh, you might pull up the bladder neck, and this results in post-operative urinary incontinence. That was the wrong one. So if you look at the data in Cochrane Library, we have 4,000 patients in many studies. With mesh, there's a better anatomical reconstruction, of course, but 10 to 15% mesh erosions. And the most important thing, there is no difference in subjective outcome, quality of life, de novo dyspareunia, stress urinary incontinence, and the rate of reoperations. So there is no real advantage in the use of an alloplastic mesh, just your satisfaction that anatomically it looks better, but not the patient. So if you take the posterior compartment, there's no reason at all to take any mesh. With 86% at an average good success rate, there is no place in primary procedures to use a mesh. Of course, if you have recurrencies or complicated anatomy, everything disrupted from serious pelvic floor damage during delivery, there might be a place, but normally in primary routine, there's no place for a mesh in posterior repair. So mesh erosions happen in up to 12% after abdominal colposacropexy and in up to 21% in vaginal use. And this is a real high figure. And if you look at the dyspareunia and hyspareunia after mesh, you see figures from 28 up to 43%. And this is a real serious topic you have to look at. And of course, nobody was speaking about that in recent years, but we have to ask our patients and especially the husbands. So I have a publication of 7 hyspareunia cases where the husband lacerated the skin of his penis all the length long on a mesh erosion, which is not a very pleasant syndrome. So the urologists will come back to our meshes. So this is a big study of 5-year follow-up of 27,800 women. And they say the routine use of mesh to augment transvaginal prolapse surgery is not supported by this study. So again, of course there is a place for mesh, but there should be a good and strict indication, and we should select the patient, and she needs a good informed consent to know what she's faced with that. So the complication with mesh, as I mentioned it, now happen in the United States with the urologists. The urologists are jumping in the field that is empty from the gynecologists that stopped using it. And they use it and they see the proliferation has resulted in later trend of mesh revision surgery, of which the rate is increasing much faster than the rate of prolapse surgery. So the complication in the field of urology is the same one. So the big problem, if we look at all these studies, they are so difficult to be interpreted. We have prosthetic, we have retrospective studies, we have objective, we have subjective data. Some are by telephone interview. What does that mean? I don't know. Questionnaires are nice, but they are not decisive. A follow-up of 3, 6, 12 months, I don't know. At the moment, laser therapy is in mode. I know in Poland, a lot of people are losing laser. The long-term results are 8 weeks. Sorry, I'm not interested what the result is after 8 weeks. I would like to see what happens after 5 years, whether the woman is still happy and still has a disappearance of her prolapse and not just a shrinkage of the scar you produced by the denaturation of laser. So this is a very different problem, and the expertise of the surgeon is one of the decisive things. And even Cochrane can be mistaken. Around the world, everybody knows that colposacropexy is superior to sacrospinous ligament fixation. But there's only 2 studies, the one of Benson and the one of Maher. Maher had no difference. And Tom Benson, I knew him, he started with sacrospinous ligament fixation in his learning phase in the study. And he did a bilateral one that has never been promoted. And he had so many complications with his, for him, new operation that he stopped the arm of sacrospinous fixation. So at the end he said colposacropexy is superior, and Cochrane took this message. That's why all around the world we are told that the laparoscopic or open colposacropexy is superior to sacrospinous ligament fixation, which is not true at all. There is no data proving that. And what happens, and this we have to take in account, that the message by Cochrane, of course, is taken by the scientific community. You see that the sacrospinous ligament fixation went down after this publication, and the sacrocolpopexy went up. So you use Cochrane as a Bible. Everything is done that is written in Cochrane, even though there is no real scientific basis to do that. So, this is from my last year visit to Warszawie. What influences the effectivity of pelvic floor surgery? It's the correct selection of the patient, it's the correct indication, it's the right surgeon, it's the correct technique, it's the cooperation of the patient, of course. She has to follow your advice. And it's, as I told you, the anticipation of the patient. What does she anticipate as a success of her surgery? It's always the wrong one. And it's luck or fate. To be honest, that is our everyday life. We can be lucky, we can have bad fate. So what should we do? What we did already, we tried to classify the complications. It looks complicated, but if you go using it, it's not that difficult. So this is a classification of the use of alloplastic materials, and then I encouraged the whole group to do the same thing, to be fair, to traditional repair. So came the same classification of complications after traditional native tissue repair. And there's 3 aspects of this scientific classification. It's the category where it's localized, asymptomatic semantic infection. It's the time when it appears, and the site where it happens. But we forgot a couple of things. We forgot the subjective complaints of the patient, of the husband, the dyspareunia, voiding dysfunction, multiple problems. So we still have to work on this classification. And if you look at the literature, there's classical complications like urinary tract infection that happens in all reconstructive surgery in pelvic floor, hematoma, defect healing. But these are not all. And if we take the transobturator approach, where is the pain in the groin and the upper thigh? Which is not mentioned in any of these complications, which is very serious. And where is dyspareunia and dyspareunia? In my own experience with now more than 500 reoperations after complications of alloplastic material, you see the technical problems. Wrong technique was the most frequent one. The indication was wrong. So we should not talk about the materials and kits, but wrong application in wrong indications and wrong surgical technique, which is our problem, not the problem of the industry. So see one, do one, modify one is a very dangerous strategy. I would warn from that. And this is just some examples of the defect healing and how we categorize it. You see these paravaginal defect healing, which produces pain for the husband. And of course we can have fistulae. My own pictures are a little better. There you see you go with the scope right through the urethral fistula after insertion of an alloplastic sling. And the reason why I show you that one is that you have to know who is to repair that. Of course there's a tendency that the one that produces the complication wants to make it disappear, but if he has no skills, the success rates are very bad. You see stress urinary continence and all the other symptoms have to be in the hands of a skilled surgeon who knows how to do that. And again, the urologist at the very beginning tried to do a urinary diversion all at once with a wet stoma, which is not justified in a small complication like that. So these are major degrees of complications. These are all slings that have disappeared. the necrotizing fasciitis. I thought three cases like these that are really dangerous. They have a mortality of around 30 to 40%. And new complications we knew from the old Marshall Marchetti Kranz, osteomyelitis. If you scratch the bone with the transobturator approach, this patient had 9 operations together with the traumatic surgeons to reconstruct the pelvis just after a simple mid-urethral sling. So how do you classify a complication like that? It's very difficult. Again, pain in the, with the transobturator approach. If you look at the complex anatomy of the pelvis, it's quite understandable. If 2/3 of the way you go through is blind, you don't know which structures you hit, and then you have an entrapment of the nerves, and Monsieur Possover in Switzerland has to dissolve all these obstructions. It's very, very complicated situation. Of course, you can do everything by robotic surgery, advance or gimmick. If you look at the data, it's very simple. There is no data on that. And of course, it's associated with high costs. So if you have enough time and a lot of money, you can use robotics, but otherwise there is no advantage to use that in classical reconstruction. And again, United States, this is a number of legal cases in the recent years with the use of robotics. So as everybody tries to use his Da Vinci, they produce new complications like with the alloplastic meshes. So always be aware of these problems. What should we do? After many of well-known products have disappeared from the market, we should rediscuss the indication. We need adequate data, and Me Too products are out. I would be very careful if a company presents a very new product. If they have no data, I would not use it. And I try to look in the internet what is left from the big leading companies. It's a very small market. There's very little that is left on the market because most of the big leading companies have taken their meshes out, and that is all that is left from Johnson & Johnson, AMI, Boston Scientific. So in the future, our major problem will be to find an adequate mesh available in your country. There is, of course, a report from the EU, a scientific committee from the European Commission that has recommendations. Ensure the patients are correctly and comprehensively informed, establish European implant registries, establish scientific studies to assess the long-term safety. For me, that is at least more than 5 years, not a couple of weeks. Support further research into novel products and establish evidence-based European guidelines. And we need training programs, and the training is the most important thing. Just to show you how complicated and how wide your spectrum has to be, that is my repertoire I had for patients with prolapse incontinence. Of course, I use TBT and TOT. I use colposuspension suspension and paravaginal defect. If I have stress incontinence and prolapse, I do a 2-step procedure. Primary prolapse, I would use native tissue. Apical prolapse, I would use a sacrospinous fixation. Recurrent, the colpopexy. Multiple recurrence, here I use meshes, of course. And with multiple failure and stress urinary incontinence, I would use an intraurethral injection. So you see, to have an adequate offer to your patient, you need a full armamentarium of operations, and we should always be aware that surgeons are not smarter than any tailors. That is a technician from the traumatology. So my result, I love Edwards Deming. He said, in God we trust, all others bring data. And that is my message. So